This lecture will focus on assessment of the cardiac patient. All right, so when we're thinking about the EMS assessment of the cardiac patient, we have to remember that we're going to start with our primary assessment and our scene size up. So in our scene size up, we want to make sure that the scene is safe. These are generally medical patients, right? Scene safety may or may not be an issue. We want to determine the mechanism of injury or nature of illness. Again, these are usually medical patients, although trauma to the chest can also cause chest pain. We want to make sure we're taking appropriate PPE. So PPE would include gloves and then other PPE depending on what other things are going on with the patient. Determine the number of patients. Usually for these medical patients, there is only going to be one, but there could be more, right? And then consider additional or specialized resources. Some of the situations where you might want to consider additional resources would be a patient who's having an acute myocardial infarction. Patients with acute myocardial infarction can go into cardiac arrest. And so you might need more people to take care of that patient. A patient who's already in cardiac arrest would be another example of a patient who would need additional resources. You may consider how far away you are from a local cardiac facility where they could do stent placement. And if you're far from there, you may need to consider air transport for your patient. And then consider the need for spinal motion restriction. What I will mention on this is that any patient you find on the floor, you may want to consider C-spine. So consider like cardiac syncope. They fell. We want to rule out a C-spine injury. Consider the need for C-spine if you have both, you have a trauma medical patient, right? Then you're going to move into your primary assessment. So in your primary assessment, you're going to form your general impression. You're looking at the level of consciousness of the patient. How alert are they? Are they interactive with the environment, right? You're looking at their skin. Some of your cardiac patients are going to be pale, gray, or cyanotic. You're going to look at their work of breathing, which could be normal or increased, right? If they don't appear to be moving or breathing or any of those things, then when you approach them, you're going to, hey, are you okay? Assess level of responsiveness. And then in that situation, you're going to assess circulation, then airway, then breathing. But in the conscious patient, right, we're going to ask them, hey, sir, ma'am, what's going on today? Oh, I'm having chest pain. My chief complaint, chest pain. Their airway, it's open and patent. How do I know? Because it answered my question when I said, hey, sir, ma'am, what's going on today, right? If you have gurgling, snoring, or stridor, the airway is in need of being cleared, right? We're going to assess the work of breathing, so not just from the door, but actually assesses. We're looking at rate, depth, and effort of our breathing. Patients who are having heart attacks, patients in acute heart failure, along with several other cardiac complaints may have difficulty breathing. We're going to assess circulation, so we want to know about the rate, regularity, and strength of the pulse. We want to know about skin, color, temperature, and condition, and we want to assess capillary refill. Then we're going to move on to our disability assessment. So for any patient who is unresponsive or altered in any kind of way, we want to make sure that we're checking pupils and checking a blood sugar. Then we're going to expose our patient and assess further, right? So in the medical patient, there's no trauma. That has no trauma, we may expose. We're doing more of a visual exam. Certain things we definitely want to look for, right, or look at. We want to look at accessory muscle use. We want to listen to lung sounds. We want to listen to heart tones, maybe palpating the abdomen, looking for things like swelling. A lot of this is going to be tailored upon what the actual complaint of your cardiac patient is, because they don't all have chest pain, right? And then we want to establish patient priority and make a transport decision. I want to emphasize that patient priority and transport decision doesn't necessarily mean every patient gets thrown in the back of the truck because they're high priority. What we're doing is we're saying this is a high acuity patient. I need to prioritize these few things on scene, and then we need to go. It doesn't just mean throw them in the back of the truck. Okay, so follow your local protocol, but so in general, patients who are having acute myocardial infarctions need to be transported rapidly. Patients with shortness of breath need to be transported rapidly. We're moving away from throwing every patient in cardiac arrest into the back of the truck and just leaving with them, right? Now we're looking at more of a work on scene. We have better outcomes with that. After your primary assessment, or with your primary assessment, we'll give you a scenario here. So you're dispatched to a 74-year-old male patient. He's supine on the floor. His eyes are closed. He does not appear to be moving. He does not appear to be breathing, and he is pale. Okay. Now what? Okay. So you're going to approach this patient. What you want to know is he dead, right? you want to make sure he's not dead. So you're going to assess, rather than A, B, C, we're going to assess C, A, B, right? So, hey, are you okay? They're not responding. I'm checking a pulse while listening for breathing, right? And if they don't have a pulse and are not breathing, we're going to start CPR, right? If they have a pulse, but they are not breathing, then we would initiate BVM ventilations, okay? As part of your assessment, you want to obtain your history for your patient. So we want to get the history of present illness, which is going to include the onset. So if they're having chest pain, when did it start? Was it gradual or sudden, right? Does anything make it better or worse? So if they've taken maybe aspirin or nitro, is their pain better than it was, right? Does sitting forward help? Is it worse when they lay flat, right? So what makes it better? What makes it worse? Is it worse with exertion? Is it better with rest, right? How would you describe your pain if you're having pain, right? So the quality of the pain or the shortness of breath if you've had it before. Is it, crushing? Is it dull? Is it sharp? Do we have point tenderness? How would you describe the pain? Does it go anywhere? So does it radiate? Cardiac pain will often radiate to the jaw, the arm, right? It doesn't have to, but may radiate to places like that. Can you put a number on your pain scale, right? So the severity on a scale of 0 to 10, rate your pain. It's going to be important because when we treat pain, we want to reassess the severity. Has it gotten better, worse, or is it about the same with our interventions, right? And we also want to ask about kind of onset and time, gradual, sudden, how long ago, right? And then any interventions that were done prior to arrival. Okay, so did dispatch tell them to take aspirin? Did fire department give them aspirin? Did they use their home nitro and take aspirin on their own? I want to ask about things like that. We also want to get their past medical history. Signs and symptoms are going to be kind of an expansion on what you find and what they complain of, right? We want to make sure that they don't have any allergies, and if they do, that we have them documented. We're not giving them anything they're allergic to. We want to get a list of their current medications. Keep in mind over-the-counter medications that they may have taken. So ask about over-the-counter medications, or alcohol or drug use would fall under this as well, right? We want to ask about their past medical history. A lot of your cardiac patients have things like hypertension, they have hyperlipidemia, they may have diabetes, right? So these are common things that we see along with cardiac history. But remember, you don't have heart history until you've had a heart problem. So you could be dealing with a patient who has no cardiac history whatsoever. You want to ask about their last oral intake, and you want to ask them about the events leading up to calling 911, right? Oh, I was outside cutting the grass and I had a sudden onset of crushing chest pain. I came inside, I thought I was just, dealing with the heat or whatever. I came inside, I sat down, had a glass of water. It didn't go away, and then I started feeling aching in my arm. I called 911 right away. Okay, so events leading up to, what were they doing, right? Okay, so ask about these things. All right, let's talk about acute coronary syndromes, okay? Because a lot of this is going to focus on ACS, but not everything we talk about today. So acute coronary syndromes are a series of cardiac conditions caused by an abrupt reduction in blood flow through a coronary artery, okay? So patients having some version of a heart attack, right? There's reduced blood flow, they're going to have ischemia, and they're going to have chest pain, right? Or a chest pain equivalent, right? So these can be broken down, these acute coronary syndromes can be broken down into unstable angina, NSTEMI, and STEMI. So if you're unfamiliar with these terms, NSTEMI is a non-ST segment elevated myocardial infarction. STEMI is an ST elevated myocardial infarction. We're going to talk about 12 leads, and with those 12 leads, you guys will learn how to identify STEMIs. Okay, obviously, ST elevation on an EKG, and then non-STEMI would not have that. Okay. All right. What are common complaints of patients with acute coronary syndrome? So angina would be a really common one. The patient calls you for chest pain, but what else? Think of a few. Okay. Things like, well, I'm not going to tell you because you guys are going to have a question on that, but what are some common complaints of patients with chest pain? Okay. Put some down in the question, the relevant question. All right. Some common cardiac medications that patients may be on. They may be on antidysrhythmics, so things like digoxin. Okay, so digoxin is a cardiac glycoside. It's used commonly for AFib and heart failure. Procainamide and amiodarone are common antiarrhythmics that we see patients on for atrial and ventricular arrhythmias. And then verapamil would be an example of a calcium channel blocker used to control rate. Other examples of calcium channel blockers would be like diltiazem, right? One we give in the field pretty commonly. Patients may be on anticoagulants like Lovenox, Plavix, Coumadin. This may be because they've had a heart attack in the past. It may be because they've had a stroke or a TIA in the past, and it may be because they have an irregular heartbeat like AFib, right? So those are some of the common reasons they would be on anticoagulants. Another would be a history of like deep vein thrombosis or pulmonary embolism. They may be on coagulants for that. Patients may be on ACE inhibitors. Okay, so ACE inhibitors are going to disrupt that renin, angiotensin, aldosterone system that you guys loved so much in pharmacology, right? And those are generally used for patients who have hypertension, right? So these are going to be your prils, captopril, enalapril, lisinopril, among others, okay? For patients who are on ACE inhibitors, they often complain of a dry cough, and if they can't tolerate that, they may be moved from being on an ACE inhibitor to being prescribed an ARB or an angiotensin II receptor blocker. These are things like losartan, valsartan, etc. Okay. Patients may be on beta blockers. Okay, so as you remember from pharmacology, beta blockers are going to work on your beta 1 receptors. They may also work on beta 2 receptors. As a beta 1 receptor blocker, we're going to decrease heart rate. We're going to decrease contractility. Okay, so these are good to decrease cardiac output. Some of them are also alpha blocking medications, which will cause vasodilation. Okay, so atenolol, metoprolol, those are beta 1 selective with no alpha properties. Propranolol works on beta 1 and beta 2. Okay, there's not a good reason to block beta 2, but we hadn't gotten that good at making medications yet. You may also see patients taking things like labetalol. Okay, labetalol would be an example of a beta blocker and alpha blocker, so better for hypertension, where things like atenolol and metoprolol would be better for rate control rather than for hypertension. Usually if they're used for hypertension, they're going to be used in conjunction with another medication. Patients are going to be on lipid-lowering agents. Okay, so patients who have high cholesterol or high triglycerides would be on a lipid-lowering agents. These are your statin drugs, atorvastatin, fluvastatin, rosuvastatin, simvastatin. Okay, they may also be on diuretics. This is common in patients who have congestive heart failure or have any kind of renal disease, right, or hypertension. So things like Lasix or hydrochlorothiazide, HCTZ would be examples of that. Patients may also be prescribed vasodilating medications like nitroglycerin or isosorbide. Okay, so patients who are prescribed nitroglycerin may have already taken it prior to your arrival because they are having chest pain, and the goal of that, things like nitroglycerin, is going to be to reduce preload, reduce myocardial oxygen demand, and hopefully relieve pain. You want to ask specifically, if the patient doesn't volunteer this history, you want to ask specifically about history of aneurysm, atherosclerotic diseases. So atherosclerosis is plaque that builds up in the arteries, right? So atherosclerotic diseases would be things like angina, right, that causes ischemic chest discomfort, right? Previous heart attack because of plaque buildup, hypertension, and heart failure. You may want to ask specifically about congenital anomalies, coronary artery disease, diabetes. Diabetes is a big risk for your acute coronary syndromes and for coronary artery disease. You may want to ask about inflammatory cardiac diseases, things like being diagnosed with myocarditis or endocarditis. Okay, previous cardiac surgery, which hopefully you notice when you expose that they have a big zipper down their chest, right? They may have had a CABG or a coronary artery bypass graft. They may also have had valve replacement surgery. Okay, so ask about those things. Ask about pulmonary diseases. We call it a cardiopulmonary system. So diseased pulmonary systems can cause problems with the heart, valvular diseases and vascular diseases. Okay. All right, when it's time to do your secondary assessment, which of course your history is part of, right, you have to decide whether what kind of exam you're going to do, right? So are we doing a full body exam? Are we doing a rapid full body scan? Are we doing an exam that's focused on the injury or based on the body system? Okay, so in this patient, a cardiac patient, you may want to do something that's focused on the body system, right? So we think about the heart. Remember that the cardiovascular system is everywhere. They had chest pain, but they could have JVD. They could have peripheral edema. So we're going to focus on the chest, but we want to look for things like that too. They may have ascites. Okay, so look for things like that. You want to get a baseline set of vitals, and you want to make sure that throughout the course of your care and with your treatments, we're reassessing those vitals. We want to use monitoring devices as appropriate. Cardiac patients should be on a cardiac monitor. They should receive a 12 lead, preferably more than one. Okay, and then perform any additional treatments that you find appropriate at the completion of that secondary assessment. So at this point, we're going to talk about the secondary assessment and findings that are specific to, well, more specific to cardiac patients, right? So some of the things that you might find are abnormal pulse findings in cardiac patients. So they may have a pulse deficit. Okay, this is where there's a difference between the palpated peripheral pulse and the auscultated apical pulse, right? So I'm palpating the radial pulse and it feels like it's about 110, but when I listen to the heart, I hear it at like 140. Okay, so this may be that the heart is contracting weakly or they have an abnormal rhythm. Sometimes we see this in atrial fibrillation. Other rhythms can produce this as well. Pulsus paradoxus is another abnormal pulse finding. So this is when the systolic blood pressure drops more than 10 millimeters of mercury with inspiration, okay? Which sounds a little crazy because we're not actually gonna like, hey, hold your breath, I'm checking your blood pressure again. That's not how this works. What you would notice is that the quality of the strength of the pulse would change when they breathe. So if you're palpating their pulse rate for 30 seconds, right, then they took at least, hopefully, took at least 6 breaths during that time. And when they breathed in, did the pulse get weaker, right? So that would be a finding of pulsus paradoxus. Some of the things that can cause that: acute myocardial infarction, cardiogenic shock, cardiac tamponade, and constrictive or restrictive pericarditis. Okay. Another finding that you might have is pulsus alternans. So this is a beat-to-beat variation in the strength of the pulse. So you're palpating the pulse and it's like weak, strong, weak, strong, weak, strong. This is seen with severe ventricular failure. Blood pressures can also be abnormal in cardiac patients. So depending on when you got your EMT, you may not recognize the new versions of blood pressure. So historically, we said you weren't hypertensive until your blood pressure was 140/90. That is no longer the case. Okay, so let's talk about normal blood pressures, and then we'll talk about the other findings. So normal blood pressure is now defined as less than 120 over less than 80. So systolic that's under 120, diastolic that's under 80. You're considered elevated if you're between 120 and 129 systolic, and you're still under 80 with your diastolic. In stage 1 hypertension, your systolic is 130 to 139, or your diastolic is 80 to 89, right? And then you're in stage 2 hypertension if your blood pressure is over 140 systolic or greater than or equal to, or greater than or equal to 90 diastolic. So you may have diastolic hypertension, but your systolic may be normal. Okay, so those are the newer guidelines for blood pressure. Okay, patients who have cardiac problems may present with hypotension. Okay, so why would they be hypotensive? If something's wrong with the heart and you have decreased cardiac output, right, it would stand to reason that your blood pressure would fall. They may have hypertension. It's a common finding in cardiac patients. They may be in an acute hypertensive crisis, right? For example, you may also find narrow pulse pressure. Okay, so in narrow pulse pressure, the diastolic number rises and the systolic number drops. This occurs for a couple reasons. One, the heart rate is too high. Okay, so when the heart rate is too high, the heart doesn't get time to fill, and so when it contracts with less blood in it, and the systolic or the contraction pressure, right, falls. And in an effort to maintain perfusion, your vessels constrict, so your diastolic pressure rises. Okay? In cardiac tamponade, the heart has impaired filling because it's being restricted from the outside. Imagine that I gave you a balloon and asked you to blow it up. The balloon represents your heart. I have put my hands around that balloon and asked you to blow it up. Are you going to be able to do it? No. Okay. And in tamponade, it's the same way. You have pressure that's built up around the heart, and you're still trying to fill it from the inside out, and you can't do it. Okay. So in cardiac tamponade, you have impaired filling and impaired contractility. And so again, the top number, the systolic number, falls, and we compensate by increasing our systemic vascular resistance. Okay, and so our numbers get closer together. And then in heart failure, if your heart is failing to squeeze adequately for any reason, right? You have systolic heart failure, then the same thing could happen. That number falls and the diastolic number rises, and this creates a narrow pulse pressure. Okay. All right. So what you're hearing in the background is a normal heart. Okay. So normally when we listen to the heart, we listen and we hear lub dub, lub dub, lub dub. Okay. S1 is your lub sound. It represents closure of the AV valves. Okay. It is the onset of ventricular systole. So when the ventricles begin to contract, okay, the back pressure forces the AV valves closed and opens the semilunar valves, and blood leaves through them. Okay. The S2 is the dub sound, and it represents closure of the semilunar valves, and it's the onset of ventricular diastole or rest. Right. Blood is no longer exiting the heart, exiting the ventricles into the aorta and the pulmonary arteries, okay, or the pulmonary trunk, and the heart is now at rest. Some abnormalities that you could hear would be an S3 sound. So I'll give you a second to listen. All right. So the S3 sound comes after S2. It's heard in early ventricular diastole, which means you hear it right after S2. Okay, so you get lub dub da, okay, or the cadence of Kentucky, 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 right? This sound occurs when blood comes into contact with a compliant ventricle. A compliant ventricle is one that wants to accept blood. It stretches and it fills really well. Okay, it could be normal in young adults with healthy hearts, children, patients who are pregnant, and then athletes. But in older patients and adults, you may hear it due to heart failure, like a dilated cardiomyopathy, for example, or when patients have severe mitral or tricuspid regurgitation, where blood backflows through those areas. Another abnormality you might hear is an S4 sound. This is heard late in ventricular diastole. Okay, so remember, lub is the beginning of diastole, dub is the end of, lub is the beginning of systole, dub is the end of systole. So if it's heard right before lub, it is in late diastole, right before systole. Okay, and what happens is that atria force blood into a stiff left ventricle. Okay, so a patient's heart that does not want to be compliant, it does not want to stretch, it does not want to fill, and so blood is being forced into that stiff ventricle. We would see this with something like severe left ventricular hypertrophy, where the ventricle gets very, very big and doesn't want to stretch, and it is never a normal sound. Okay. All right, so some of the abnormalities that you might see in cardiac patients, we will talk about more of those abnormalities with each individual disease process. Okay. Once you've completed your assessment, right, your primary assessment, you've obtained your history, your secondary assessment, you've done at least one round of treatments, now we're on to our reassessment. Remember, we reassess patients every time we move them, and then we reassess them with any change in condition, and we reassess them at 5 or 15-minute increments depending on how critical the patient is. So 5 minutes for an unstable or critical patient, 15 minutes for a stable or non-critical patient. When you're doing your reassessment, you want to repeat your primary assessment. Okay, so let's say I had a patient with chest pain. I'm going to knock out LOC, chief complaint, and airway all at once. Okay, I've moved my patient to the ambulance, and I go, hey, sir, you said your chest pain was about an 8 earlier before we moved you. Can you tell me how your pain is now, or if you're having any pain? If he responds, and he's alert, right? He can talk to me. His chief complaint, did it get better or worse? He tells me it's an 8. His chief complaint's gotten better, and he said it with clear speech. His airway is open, right? We're going to reassess breathing. What's the rate, depth, and effort of his breathing? We're going to reassess circulation, right? So pulses, skin, color, temperature, condition, cap refill, disability, if they've had any change in their mentation, right? Then we may need to check a blood sugar or pupils at this point. And then we're going to obtain a new set of vital signs, okay? We're going to recheck any interventions that we've performed, right? And we're going to identify and treat any changes in the patient's condition. So this may be we're giving more medication. This may be that the patient's condition has changed rapidly and we're in a whole new protocol, okay? So that identify and treat any changes in the patient's condition.